All right, you want to run a great code, you got to get organized. And we're going to talk about the REANIMATE style of how to do this. There's three main changes that we make. The first is that we let our nurses run the code. The second is that we have explicit rules for each person. And the third is we set up the room in order to have success. This is the so-called ergonomics of resuscitation. Now we're going to take a look at these schematics throughout the course of this video, and this may be a little overwhelming at first. But the most important thing here is understanding that there are a limited number of people who have explicit roles. The first person I want you to see is the code team leader. That person is running the code and is a nurse out on the side. Up top is the alpha doc, and that person is doing the procedures outside of cannulation and figuring out all the components of the arrest. You have two ER techs that are up at the head of the bed who are responsible not only for setting up the room, but for managing the chest compressions and the chest compression device. Lastly, we have over on the side the line doc who is responsible for cannulation. On the other side of the bed there is a med-electric nurse, and this nurse works directly with the pharmacist who's standing behind as far as what medications need to be given, how much needs to be given, and when. The pharmacist has a pharmacist box that really helps us to get organized as far as the medications during the arrest. There's also a circulating nurse that's over at the end, and this allows us to go and gather supplies during the arrest. As far as a respiratory therapist, they help us in the intubations and allow us to move forward with the code. So let's look at each of these components, and starting off with how do you set up the room, the tech's job.
Before the patient comes in, I'm going to prep the room. So that's going to have the line cart and the crash cart. We're going to have our ultrasound machine. We're going to have our Lucas for chest compressions, and we're going to coordinate with RT if there's an intubation that needs to be done.
So this means we got to put these things in the right place. Now look at this schematic a little closer. Here's the crash cart, here's the resuscitation cart, and the Mayo stands are where we put the lines. Another concept here is that we try and transition our patients outside of the hospital where there are less people, or we'll have less delays as far as transitioning to quality chest compression or mechanical chest compression device. We've coined this term CPR al fresco.
Eliminate as much as possible. What doesn't need to be there needs to go. Chairs, stools, linens, everything's got to get out. So we clear out as best we can, get our team together of who's going to be in the room.
All right, eliminate unnecessary things. Let's now talk about after the patient arrives, and the pinnacle of this is our code team leader, RN.
The code nurse's responsibility is to make sure that the room is set up the way the physicians would like the room to be set up, to place the med-electric nurse, the gopher or the circulating nurse into an area that will best facilitate the code and to help anticipate what the physicians may need. She or he is going to stand back in the room, kind of oversee, make sure that CPR is being done correctly, check the timing of the medications, check the timing of the pulse checks, offer medications that maybe the physicians haven't thought of, make sure cath lab is called, make sure that our ECMO team is called if the physician decides that this is an ECMO candidate. She or he is going to be the eyes and ears backup for the physician to make sure that they can do the mechanics of placing lines and cannulating and having the physicians concentrate on actually the procedures of the patient.
Okay, paradigm shift. The code team leader nurse is now running the code. As physicians, we need to relinquish that responsibility to them. They are taking care of all of the usual stuff. Are chest compressions being done well? Are the medications being given? What is the timing? And so they're going to offload some of that off of the physician. The physician now has the continued responsibility of finding out what's going on in the code. Let's move on to the med-electric nurse.
The med-electric nurse operates the crash cart, the places pads, also administers all medications.
All right, this goes into how important we think pad placement is. We've got to get that lateral pad in the right place. Now this picture is showing dual sequential defibrillation with 2 sets of pads. But the one I want you to look at is that lateral one, the one that's over the left costophrenic angle. You got to get that pad placed at the point of maximal impulse, or else you're just not getting enough of the heart defibrillated. So who places these pads? It's the techs. And so this really leads into the importance of training your people to do the right thing at the right time. Explicit roles. The second thing that our techs do so well is chest compressions.
Maintaining chest compressions for a CPR patient. So we'll, if the patient is coming over to our gurney, we're going to maintain our manual as long as we can, but then we'll switch to Lucas as quick as possible. That means rolling the patient, getting their backboard underneath, fastening in a device, and then once that's fully operational, I focus on vitals, EKGs, and that stuff.
Again, explicit roles, so important. Setting up the room, so important. All right, let's talk about our pharmacist and how he leads into the idea of making this code successful.
From a pharmacy perspective, I think an ER pharmacist should have a strong grasp on all medication issues associated with the code. So anticipate what is going to be needed. For example, if a high-dose insulin protocol is started, a lipid protocol is started, or even pressors are initiated, the pharmacist should be able to dictate all the titration parameters and get those processes started from A to Z and anticipate changes in needs. For example, if a patient is, we have a ROSC patient that has received several doses of epi, and now the patient comes back hypertensive, the pharmacist should prepare pressors in anticipation of that drop in blood pressure. Some of this comes with experience, and some of this comes from just knowing the data and certain protocols. I think having a good pharmacist at the bedside will allow the physician to free up their hands and basically brain power to do what they've been trained to do, and let us kind of take care of that. For example, the vasopressin steroid epi protocol. When we have a patient come in who requires such a protocol, it is can you just kind of get the VSE protocol started, and then we will prepare and make all medication, administer all medications, and assist the nurses in giving those medications from A to Z. One thing I do at the beginning of every code is trying to make eye contact with the lead physician and make eye contact with the nurse that is going to be handling those meds. So those are going to be my 2 points of who I am working with. We have a code box such as this that has everything you can imagine under the sun, and having a good labeled, alphabetized code box that the pharmacist is aware of in the code makes a night and day difference, so you're not running back and forth. Another thing that the pharmacist can help with is, again, with the medications, sedation. Once we paralyze our patients and they come back, what sedative medications do we give, how much, how is that going to affect the blood pressure, and when to start them, when to hold them, and how to titrate them is a big portion of what we do.
I think you can see how useful a talented pharmacist can be for your code. Let's look at the Alpha Doc and how you now have to change your thinking about what the main doctor in the room's role is.
The role of the Alpha Doc is to make the cognitive decisions that come up as part of the code. The actual running of the code with respect to ACLS protocols, times, shocks, drugs, and so forth, that is offloaded to the code nurse. Alpha Doc will run the airway, is responsible for interpreting rhythms, is responsible for making decisions about how the code is going to progress. In a case that is potential for ECMO, then the role of the Alpha Doctor is to make a decision as to whether or not, first, is the patient a candidate for ECMO, next, if so, then to direct his colleagues or her colleagues to establish access in the groin such that ECMO cannulas can be performed. As well, the role of the Alpha Doctor is to oversee placement of invasive lines that are going to help us run the code. So in our codes, we're going to put an arterial line in all of our codes. We're going to put a central venous line in all of our codes. If appropriate, the Alpha Doctor will intubate the patient, and the Alpha Doctor will work closely with the code nurse to see how the code is progressing. As well, oftentimes the Alpha Doctor will be the one who does things like cardiac ultrasound, A-line interpretation, push dose pressors, selection of various non-ACLS drugs as part of the resuscitation. Also, we'll make the decisions in terms of things like hypothermia, resuscitation fluid, placement of hypothermia catheters, and then other sort of non-standard resuscitative measures. For example, the use of solumedrol, the use of vasopressin.
Last but not least is the line doc. Importance cannot be underestimated here. The line doc is responsible for cannulation. They own this part of the real estate. They have 2 Mayo stands. If we have a second doctor, we can use that second Mayo stand. There's a resuscitation cart here in the back, which has everything you'll need for your resuscitation. And for a right-hand dominant person, we put the ultrasound on the right side so that they can use that for cannulations. All right, once you've decided that you're going to go on to ECMO with this patient, we then have an ECMO cart behind us. This ECMO cart has everything you will need. It has cannulas, it has dilators, it has advanced dilation equipment such as use of the Amplat SuperStiff. It has a cut-down tray, and it even has a tray for sternotomy. When we start talking about the details of cannulation, there certainly are different types of cannulas. I have you shown here both the Medtronic type as well as the Mackay type. The idea though is that you will have a dilator kit within the Medtronic side. On the Mackay side, you will have a separate dilator kit that will come in a separate package. Both of these will take a lot of space, a lot of real estate, and so you need parts behind that gurney so that you're going to have enough space to have ergonomically everything set up so that you can successfully put these long catheters into the groin. All right, let's put this together. What does a REANIMATE ideal resuscitation look like?
Say that the main differences are the noise level, there's no yelling, the stress level is greatly reduced, the teamwork, because the codes are run by the nursing staff who are collaborating with the doctors are able to make decisions.
All right, take home points. Resuscitation is a complicated thing. It takes teamwork. Main things we're talking about: nurse-led codes, explicit roles, setting up the room correctly. And that's how you run a REANIMATE resuscitation.